Well, good morning, everybody. Thank you for being here. We are delighted to have Dr. Collin Stultz with us this morning. This is the third keynote session within our AI Week event. Let me give a quick, brief introduction of Dr. Stultz, and we'll use our time as best as we can to maximize the use of our time for his comments and his thoughts about the title of the talk is the clinical useful machine learning. How close are we? So Dr. Collin Stultz is the Nina and Robert Rubin Professor in Medical Engineering and Science, a professor of electrical engineering and computer science, and a co-director of Harvard-MIT program in health science and technology, a member of the Research Laboratory of Electronics, and an associate member of Computer Science and AI Laboratory at MIT. He's also a practicing cardiologist at the Massachusetts General Hospital, and Dr. Stultz received his undergraduate degree in mathematics and philosophy. I thought that was very interesting, from Harvard University, a PhD in biophysics from, again, Harvard University, and an MD from Harvard Medical School. He did his internship and residency and fellowship at Brigham Young Brigham and Women's Hospital in Boston, and his scientific contributions have spanned multiple fields, including computational chemistry, biophysics, and machine learning for cardiovascular risk stratification. He's a member of the American Society for Biochemistry and Molecular Biology and Federation of American Societies for Experimental Biology. He is a past recipient of the National Science Foundation Career Award and Burroughs Wellcome Fund Career Award in the biomedical sciences. His current research in his group is focused on the development of machine learning tools that can guide clinical decision making. So we are very glad that we have Dr. Stultz with us, and we'll look forward to your presentation. Please help me welcome Dr. Stultz to the stage.
Great. So since it's I'm hoping that this. I'll put this. I'd like to make this as. Thank you, Dean. It's great to be here. It's been wonderful seeing Waco, and the temperature here is quite different than it is in Boston. If any of you would like to exchange places during a sabbatical, any faculty members? December or, well, not December, maybe January or February, please let me know. Today, it's a small group, and I'm hoping we can make a lot of this interactive, and that there'll be time at the end for questions, but certainly before then, if there are questions or things or topics that come up, please feel free to interrupt. So I'm going to try to tell a story today. Clinically useful machine learning, how close are we? And there's a couple of terms here that I think we should probably go over. So machine learning. Now, machine learning is a subfield of artificial intelligence where we try to impart intelligence to machines by looking at data sets, typically large data sets. So you throw some data at a computer, and the computer looks at that data and tries to derive important relationships for some task of interest. ChatGPT, for example, is an application of machine learning. Large language models, more generally, are applications of machine learning. Lots of data, lots of words, lots of sentences. And the machine learns these relationships between the sentences and can engage in a colloquy with you. You can ask it a question, it can give you a reasonable answer. But some other things are also machine learning and fall under AI. So I don't know how many people here are familiar with logistic regression or Cox proportional hazards modeling, standard statistical techniques that have been around for decades. That's also machine learning. So although we talk about artificial intelligence and the subfield machine learning in the age of large language models and ChatGPT and associated things, we We think about it as this new concept, but machine learning has actually been around for decades. And not just as an impetus for scholarship, not just in papers and actual things that we do. So clinically, a lot of the things that I do as a cardiologist and a lot of the simple models that we use to identify high-risk patients were derived from logistic regression or Cox proportional hazards models from other data sets. So machine learning in and of itself is not new. It's been around for a while. But what is new is in some of the types of machine learning algorithms that we can leverage for different tasks. And today I'm going to talk about just a few of those and some potential applications in the future, focusing on some of our own work. So I want to begin talking about in the hospital. What happens in the hospital? So there's a lot of very young faces here, and hopefully none of you have been in the hospital, but once you start to get up there in maturity, you may find yourself in the hospital more and more. And in the hospital, there's a panoply of things that we can obtain about patients. So there are lab values, an electrocardiogram, that's where you put electrodes on the chest. You get information about the electrical activity of the heart. We can do ultrasound studies of the heart, MRI scans. We can do invasive studies, CT scans, a panoply of different types of data. So these data are very different than this. This has many different pixels that make this image. From this laboratory study, you may send it to the lab and get 20 different numbers that you can use to understand how sick the patient is. And the point being that when you're in the hospital, the healthcare provider has a great deal of information that they can use to make decisions about the patient. Right? And typically in clinical medicine, there's only two things that you want to do. You want to make people live longer, or you want to make them feel better. And you've got to decide what medications or procedures that you could use towards that end. Now, when you're at home, it's very different. The types of data that one has at home, much more limited. So we have blood pressure cuff. I'm speaking from the cardiology standpoint. You can often have a portable ECG. Maybe you can have a device you stick on your finger that you can get blood oxygenation, and your phone has an accelerometer on it. You can tell you how active you are. But the level of detail, the information content that arises from these signals is in principle much less than what you get in an in-hospital setting. I want to just make a quick point about the portable ECG. So typically, when you think about an electrocardiogram, there are electrodes that get stuck on the chest, on the legs, and you see this readout of an ECG. It kind of looks like this. But nowadays, it's not quite like that. Anybody here have an Apple Watch? That's it? Apple's got so much money, and only those. See, I'm expecting many more. So Apple's not the only watch. There's a few other devices that will do this. An Apple Watch can obtain an electrocardiogram. Right? At least the latest versions of an Apple Watch. You put your finger on it and you can get an ECG. The point being that the devices that we have that we can obtain electrocardiographic information, right, are not quite ubiquitous, but almost there. Many types of things that we could get like this, many vehicles in which to get this electrocardiogram in a home setting. So the premise here is that at home, the healthcare provider has a scant, relatively small amount of data that they can use to inform their clinical decisions. And the question is, can we use AI, and in particular, this talk is really about machine learning, to augment this information to do things that could be observed in a hospital? Can we move much of the hospital setting to the in-home setting? And this is the future. This is what we will see happen in the next decade or so with respect to machine learning. So the premise being, we can take these very simple signals, we could put them in this black box that I'm calling this deep learning algorithm, and we can get the same information or close to it as you could get in the hospital. So here, this is an invasive study that tells you about pressures inside the chest. This is this cardiac ultrasound, laboratory data. We can get other sorts of information that are helpful to decide how to dose different drugs. And so this is the paradigm. This is the future. So in other words, to say it another way, in a hospital, and this is from an intensive care unit, you have many different signals that you can acquire. And this patient is heavily instrumented, lots of different information that can occur even on a minute-to-minute basis. And what we will see is a discrepancy between the types of data that you can acquire in a hospital setting and the types of data and the insights that you can make in the home setting. We'll see a shrink in this gap. So today I'm going to talk just one story I'm going to talk you through that sort of, I think, typifies this. Here, this portable ECG, I want to talk about information that you can obtain from this portable ECG to get at some of these different types of data. So again, just to make the point, drive the point home, an electrocardiogram, typically you have many different electrodes that are placed on the chest, and then you see you have this 12-lead electrocardiogram. Each of these represents a different view of the heart, a different view of the electrical activity of the heart. But nowadays, you can do that in very simple devices, an Apple Watch, for example. I think that's an Apple Watch. But there are several watches in which you can get this sort of information. And they're patch monitors, things that we can place on a patient's chest, keep this on for about a couple of weeks to get information, about the ECG. And there's also another thing, loop monitors that you could be implanted underneath the skin that you can keep in for years at a time. So only to point out that this information can be readily obtained in an in-home setting. And I'm going to discuss how you can leverage this to be able to get this sort of information. So what's the paradigm? What will the future look like? So leveraging ECG data to guide the care of patients with cardiovascular disease. You can imagine a patient that has a device that records the electrocardiogram over time. This gets sent up to the cloud. It gets processed using one of these algorithms that I'll discuss to get this sort of information. This information goes to the healthcare provider, and the healthcare provider can integrate this information in their clinical decision-making and then contact the patient if there is a problem. So it's a closed-loop system, and in the sense where we can get a lot of the information you could get in an inpatient setting, an outpatient setting, and inform the patient accordingly. One point to make that I do want to stress is that the information that is imparted to the clinician, being the same as what it is in a hospital, is not dispositive in and of itself. So the statement is not here, the information provided, this patient's going to have this bad event and you should do Y. That's not the statement. The statement is just as a clinician integrates all of these different information and uses it with their clinical insight to make a decision. So this is informative. What's provided by the algorithm is not a statement to say that you have to do this because this is going to happen. It's integrating all of these data to determine what their risk profile is. So this is a piece of data. AI in general is going to be, in a clinical setting, most useful when it's presented to the clinician in a manner that they can integrate it into their own clinical insight, their own knowledge of disease to make decisions. So, and I think I'm going to talk about some of the work that has been done in conjunction in my group at MIT and Mass General Hospital towards this. So I want to speak about one particular case, I think, that highlights the power of this, I think, most efficiently. And this is in looking at this invasive test. And this is called a pulmonary arterial catheter. I'm going to tell you what that is in a minute. So first, got to talk about heart failure. So heart failure, the definition is what it sounds like. It's an inability of the heart to provide an output, provide enough blood to the body, so it's not in proportion to what the body needs. Now, heart failure can begin in a variety of different ways. There's some initial insult, myocardial injury, let's say a heart attack, myocardial infarction is another term for it, can be a cause of it. It can be an infection. It can be an illness. Sometimes we don't know what the initial insult is, but that leads to decreased performance, and then the heart output goes down, and then the brain says, well, the heart's not getting me enough blood, so I'm going to pour out all of these neurotransmitters. I'm going to try to rev up the heart to pump more. That's what this increase in sympathetic activity is. But this increase in sympathetic activity, the brain telling the heart to work harder, makes the insult worse. So the heart's already sick, the brain is telling the heart, you got to work a lot harder, and the heart gets sicker, and so this becomes a very vicious cycle. So our own response to try to get the heart to do more actually makes it sicker. So patients get heart failure, they get sicker and sicker, and the mortality is quite high. In many studies, the mortality 1 year after your first diagnosis with heart failure is 37%. Almost 40% of people will die in a year after their first admission. And in many studies, after the mortality rates after 5 years is close to 50%, and that's worse than many cancers. Heart failure can be a lethal disease. So let's talk a little bit more about heart failure and how it's managed. So when a patient, this is time on the x-axis, and 0 here is a patient is admitted to the hospital with symptoms of heart failure. So they can't breathe, they can't lay flat because they have problems breathing, get very tired. They get tired easily when they try to move around and do what they need to do on a daily basis. Now, if you could take a catheter, stick it into a large vessel, thread it into the heart, and measure the pressures in the heart, this is what you'd find. At the time that they present, the pressures in the heart, in a particular region of the heart called the left atrium, are very high. So the heart's working really hard, the pressures are building up, and by the time that you present, the pressures are very high, and we give you medicines to make the pressures go down, you feel better, and then you could go home. But if you had this catheter in this patient at home, and you could measure these pressures starting from 3 weeks beforehand, you see that they slowly rise until the point where you have symptoms, and then you get treated, and they go down. So our treatment is generally reactive. By the time that we see you, the pressures are already very high, and it's because the pressures are high that you have these symptoms. If we had a catheter in you beforehand, we could treat you earlier. Right? So if we could identify when these pressures were elevated before you came into the hospital, we could treat you and you not be in the hospital. Right? But I don't know how many people would want to walk around with a catheter sticking out of your neck, threaded into your heart as you go to class, you go for a jog. I don't think that would be too safe. Moreover, who would put it in? How would you gauge the infection risk? Right? It's kind of a ridiculous conversation to say that this should be on an outpatient basis. But this is a central part. This is a very important part in the management of patients with heart failure. And all the time, we as clinicians are trying to assess, well, what is their left atrial pressure? Is it high? Is it low? And we use all of these low-level signals like the pulse oximeter, your weight at home to try to get a sense of what it is. Because we don't have the gold standard test because it's invasive and it entails a lot of risk to put this in, and carrying this around with you as an outpatient is just not feasible. So let's say, could you use a patch monitor or even your phone, not your phone, I'm sorry, your watch, and you can use a phone. There's some devices you could hook up to the back of your phone and you could get an electrocardiogram on. So in the home setting, you get an electrocardiogram and we could infer what the pressures were and when they started to rise, and we could treat it before you came into the hospital. So in other words, you're trying to use the data from this low-level signal, I'm calling it a low-level signal because it's easily acquired, to be able to estimate something that's deep inside the chest, that's the pressures inside the chest. So in other words, we have an electrocardiogram, and we want to infer what the pressures are. What would the pressures have been if I put a catheter into the chest and measured the pressures themselves? This is a problem that is well suited for deep learning. Well suited for deep learning. There's a hypothesis here that this information is some way contained in the 12-lead electrocardiogram, but I can't see it. Right? I don't know how to deduce that information. They don't teach me that in medical school because nobody really knows how to do it by eye. When I'm looking at electrocardiogram by eye, I'm not looking at every sample in the signal. I'm looking at it overall. I'm saying, does it have normal characteristics? Are the intervals normal? Are the shapes normal and such? But can a computer look at very fine differences between each of the samples, each of these leads to get this? And this is going to be this method that I'm using, and this is deep learning. So deep learning refers to a neural network, a deep neural network. So it has many, many layers. And there's lots of talk in the literature about neural networks and how they mimic will help people think and mimic the brain. I want you to forget about all that nonsense, right? Deep learning models are function approximators. They're very good ways of approximating very complex relationships. That's what they are. They have many different parameters. I have some inputs, and in this case, I have some outputs. The relationship between them is very complex. It's some very, very complex function. I don't know what it is. And a deep learning model learns that function. So in practice, that's what deep learning is. Now, you guys are aware that the Nobel Prize in Physics this year went to two people. Physics, one could argue whether it should be physics, but there's certainly to right, Hopfield and Hinton, who developed these deep neural networks, only to point out how important, or neural networks in general, how important this technology is and has become, and how versatile it is. And if we think about, we have complex relationships within data, we want to understand what those relationships are. Deep learning is a way to do it. You just throw data at the algorithm, and you have the algorithm learn what the functional form is. So if we have enough data, we can take this input, this electrocardiogram, throw it into a model, a deep learning model, learn these parameters, and have it predict what the pressures are. Now, there's some subtle points here. So for example, this is a 12-lead electrocardiogram. This patch monitor, I'm going to assume it only gives me one lead. Your watch, your Apple Watch or Fitbit watch, or your a live core device, the things that are used to get electrocardiograms, they give you a single lead. So this process could work, but it's really not applicable to this use case, right? So what we can do, we got to do something called transfer learning. We have our 12-lead electrocardiogram. We're going to learn the relationship between this 12-lead animal and the pressures inside the chest. There are 12 different leads here. This is just one of them. I'm going to find out the most important lead and then fine-tune another model to do this. So first I learn this complex relationship between all 12 leads, and then I backtrack and try to find the most important lead and how to map this lead to the pressures. So I could talk about this offline if people have questions, but this is just a general overview. So again, the fundamental assumption is that there's some relationship between the electrocardiogram and the pressures involved. So this is the one slide. I'll try to convey some details here. I'll just go over this quickly. So we have a 12-lead electrocardiogram. We take the signals, each of the 12 leads, we put them into some deep neural network, and the network learns some really complicated function between all of the samples and how they relate. And it gets to something I'm going to refer to as high-level features. This is a reduced representation of all of this. It's just another way of representing the 12-lead electrocardiogram. And then I can use this to train a model that identifies when the pressures are elevated or not. And this is an AUC. I don't know if the students here, are you familiar with an AUC, area under the receiver operator curve? So the way to interpret the AUC, it's a metric of success, and it tells you how well the model is able to differentiate between patients that have high pressure and low pressure. A perfect AUC is 100% or 1, means it always distinguishes between the two. To even be more precise, if I have two patients that I've measured their pressures, one patient has a high pressure, one patient has a low pressure, what's the probability that the model will give a higher score to the person with the high pressure, right? So if the probability is 1, then it always assigns a higher score to the person with the higher pressure. So it can really discriminate between high and low pressure. And so this AUC is about 0.79, about 80%. Now, if you look, I shouldn't ask questions. No, I won't ask questions. So the best AUC is 1. What's the worst AUC? Oh, that's one question. 0.5, right? It's not 0, it's 0.5, because 0.5 is a coin toss. So the worst is 0.5, the best is 1. If you look in the literature in terms of what are AUCs that we use in clinical practice for established models, 0.67, 0.7. And so this number compares quite favorably with what we use for a variety of other tasks in clinical medicine. It can be better, but it at least argues that there's sufficient information in the electrocardiogram for this particular task. So this is called an AUC curve. What it is really not important for this right now, but the AUC is about 0.79, again, whether the pressure is high or low. This term PCWP, that's a pulmonary capillary wedge pressure, it's just a name that we use for the pressures inside the heart, in particular the left atrial pressure. So this means the pressure is high. Now the AUCs tell us about the discriminatory ability of the model, how well it can differentiate between patients that have high and low pressures, but by itself it doesn't tell us how useful a model is. So we did other things. We looked at the predictive performance of the model in different settings. And here, this is a sensitivity and specificity plot, positive predictive values, negative predictive values. The most important point here is here. The negative predictive value of the model across the general population is about 97 to 98%. So if you have a patient with suspected heart failure and they have symptoms, you can use this model to effectively rule out that it's due to the pressures in the heart, elevated pressures in the heart. And so we've done this in a variety of different cases for different cutoffs, not only 15 millimeters, but 18 millimeters of mercury. I'm going to go over this. And the results have been consistent in a variety of different data sets in different settings. But now, I want to say, in talking about validation of these models, so in most AI applications outside of the healthcare space, when you strive to maximize statistical measures of success. How accurate is a model over a general population? Right? How well does a model predict an adverse outcome, let's say, over the general population? So let's say a model was 95% correct in determining whether you're going to die in a year. That's great for the 95% of the population, but it's not so great if you're in the 5%. How do you tell who's in the 5% and who's in the 95%? These are central questions that are important for applications of these models in the healthcare space that are not so much in other spheres. Understanding when the model will fail, what are failure modes, is really important. Because if the model fails to identify that person who's going to die in a year, and I could do something, I could recommend something that would prolong this patient's life, I've missed an opportunity. We as a field has missed an opportunity to save a life or to help save a life, right? And so I think that's the central point here. And so for these models, it's not only about understanding their overall performance, which is typical in other venues, in other applications, but understanding the failure modes. So we need to understand instances where the model is likely to fail. And this is a unique aspect of machine learning and AI in healthcare applications. So just as a general approach, I'll just talk very briefly about this, and I'll get to some of the more interesting stuff. So I have a patient here, and I use my model. I can predict when the pressures are elevated. I don't know whether this is right or not, right? Because it's not right 100% of the time from my previous conversation. Now, I could also take this patient, and I can make a similar prediction using another model, another method. So I could train two divergent methods to predict the same thing, whether the pressure is going to be elevated. And if these two estimates disagree, then I'll say this model or none of these models are appropriate for this patient. So I can at first say, very simple concept. I can take a patient, I can try two different predictions for the same task. If they don't agree, the model's confused about this patient, so I'm not going to believe anything that any model has to say about this particular patient. And I can use this as a paradigm to estimate instances in which the model will fail. So we developed this uncertainty score based on this principle for the models that I showed you previously. And sure enough, we say that in patients in which you are very unsure, the Breyer score, this is an estimate of the model error, is much higher than when the model is not confused. And similar statements apply for the AUC. The discriminatory ability of the model is much better when these values agree than when they don't agree. Okay, so I'm going to skip through this and get to the sort of the central point. So I have, again, my original task, I want to remind you, is I have a patient, I have a patch monitor, I'm trying to get an electrocardiogram. And then from this electrocardiogram, I'm going to infer what the pressures would be if I had an invasive catheter that went into the heart and measured the pressures itself. We've demonstrated this, and in a variety of settings. We've shown that you can identify the failure modes. These are all, again, important characteristics of applications of these models in the healthcare space. And this is using deep learning, what I've sort of described what this generally at a high level is before. So then this is where the transfer learning comes in that I'd mentioned very earlier. We've got to look at each of the individual leads, find out which one is most important. We found the lead that is the most important, and then we fine-tune this model just to work with the information from this lead. Again, a 12-lead electrocardiogram has 12 leads, and this is just one of them here because I want to focus on one lead because this device only gives me information from one lead. So then we have this method, cardiac hemodynamic artificial intelligence monitoring system. Obtains information from a wearable patch monitor or potentially a watch as well. And it uses deep learning to infer when the cardiac pressures are elevated. And again, the goal here is that you would wear this at home and then it would monitor your pressures. When the pressures are elevated, then we can do something to be proactive as opposed to reactive in our therapy. So this again, this is where we actually did a clinical trial. And so parts of this, just to talk about the paradigm in which machine learning models in the healthcare space are developed and should be developed, we think, and that is different and peculiar to healthcare applications. We think about AI and machine learning as being some special animal that is not subject to the same constraints that we do for any other therapeutic modality, which is not true. So all of these things were trained with retrospective data. But if you really want people to use this, if you want to ensure that it's safe to use for patients, you have to do this in a prospective manner. And this is one of the things I think that hinders the ability of these methods to get into the clinical domain. There's the stuff that happens in a laboratory, and by laboratory I mean in front of one's computer, on GPUs, where you do training. But then there's a part where the person interested in bringing this to the clinical domain has to get up out of their chair and go and test this and enroll patients. And see how efficacious it is. So we did a number of retrospective studies on this, data from a few thousand patients, and the performance is similarly good. And then we actually enrolled patients. I think we enrolled 100, and we tried to enroll 100, maybe about 83 or 87 patients. We placed a wearable monitor on them. We had our model that we trained, right, to estimate whether the pressures are elevated or not inside the chest. And then all of these patients had an invasive study done where they actually had a catheter placed into a big vein threaded to the heart and where they're able to measure the pressure. So we had the gold standard truth of these patients, and we had these data available before the catheterization was done. And what we found is, if you look at the performance of the model as a function of time, so for some patients, you look at the ECG data 20 hours before their catheterization. You look at it 15 hours before their catheterization. And the last time that we had was within an hour of the catheterization. And you could see the performance steadily goes up the closer you get to the catheterization. So the model is highly discriminant when the data are obtained within an hour and a quarter, about an hour and a half of the catheterization. And there's a steady trend that goes up in this way. So if the model from this patch monitor says that your pressures are high, it's the same as if you had a catheterization done within an hour and a half of that time period. And that's what we want, because we want to know what your pressures are right then and there, right at that time that the data are acquired. So yes, we view that this is a mechanism to obtain information about a coincident left atrial pressure. Now, there are other studies ongoing that I won't get into, but this was the first sort of initial study, and it's currently under review. We'll see it in press soon. So our view is as follows. And now, how do you use this? How do you use this model? So we put it on someone, we get a sense of when their pressures are going to be elevated, and then we can call into your physician, and they can make some interventions to try to prevent you from getting into the hospital. Who needs this, right? So if you are a 20-year-old basketball, right? That's good. Yeah. Yeah. Okay. Basketball player at Baylor, right? Do you need this? if you're short of breath, what's the prior probability that you have heart failure? Probably pretty low, right? And there's nothing the model would tell you or should tell you that would persuade you otherwise. So this is not a population you want to use this in. So if you're 90 years old and have a history of heart failure and you've been admitted every month with a heart failure exacerbation with these symptoms, we know your heart function is weak. Do you need this model? No, right? Because your prior probability that this patient, in a short of breath, is having another heart failure exacerbation is already there. So where is the space? And this is another consideration I think that's often ignored in a lot of the scholarship in this space. These methods are published and presumed to be accurate or appropriate for a wide range of patients. Finding the sweet spot is central. This is not good for somebody who's really healthy. It's not that useful for somebody who's really sick, really, really sick, right? It's useful for this middle ground, these patients that you're not quite sure of. So in high-risk patients, you don't need this. Patients that already have a history of heart failure, been admitted many times to the hospital. The clinical need is always in the middle, and this has been known. I'm saying this here, but this is a fact that is known. So if you looked, for example, at the probability of patients that have a cardiac event, right? So in patients that have arrhythmias, have had a heart attack, they have a high probability of having a cardiac event in the future. But there's very few of them, so the total number of patients is small. Right? Now, over the general population, most people don't have these high-risk factors, so the probability is low, but there's so many of them that the events are very high. So most cardiac events happen in patients who are not high risk. And that's just because the total number of patients identified as being high risk is low. And this has been described in many, many other papers previously. It's really this general population, right? These patients you're really not sure of. They don't have high-risk features. And of course, this excludes the 20-year-olds and others who do not contribute to these data, right? But this is the group that you really want to do something with. And what is a predictive value in patients who are not believed to be high risk? How does a model perform then? And so we did this. So we looked at the prevalence. This is your risk of having a particular disease, and then the predictive value of the model. And the upshot's the same. The negative predictive value is 95% when in these low-risk patients. So the main point I want to make here is this, right? In evaluating the use, not only is it so there's metrics of success for the model, which are different than the general metrics of success for other methods, but there's also the use case. What is the performance of the model in the patients and a population that you really think need this technology the most? Identify who needs it and what is the performance in that subgroup. So we think that the model, this cardiac hemodynamic AI system, rules out elevated pressures in low-risk patients. It's what you need. So I'm going to be fast. I think I only have like 5 minutes, 5 or 10 minutes left. So this was the first study to demonstrate that the ECG device can be used to measure cardiac pressures, and we believe that all patients with heart failure to some degree would benefit from this ECG patch monitoring. So the story here is a problem, a technology that applies to it, evaluating the success of the model, and isolating the use case from conception to the point where it is now. But where are we going? Where are we going? And I want to draw here just an analogy to, I think that everybody's familiar with ChatGPT, right? Anybody know how many parameters the ChatGPT has? Any guesses? No? I see some people like they want to say something. So it's over 100 billion parameters. Over 100 billion parameters. Very, very large model. And the size of the model has a lot to do with its performance. Remember, these neural networks are complex function evaluators. You have relationships between data, and you want to find these relationships, and they're very, very complicated. The more complicated the model, the more likely it is to capture these relationships. Now, ChatGPT is a generative model, right? So you can ask it a question and it generates words. You can start a sentence and it'll generate things that finish it. How can we use generative technology like ChatGPT in a medical space. So I'm going to talk a little bit about digital twins in cardiovascular disease. So what's a digital twin? So digital twins have been around for a long time. So if you're going to design an airplane and you want to make a modification to it because you want it to fly more efficiently, use less gas, be faster, you could actually make a new airplane with that modification and test it. It's a very expensive endeavor. But we know the laws of physics, right? So we can make changes in the computer, in silico changes, and we can test it in a simulation to determine what the effect of that perturbation is. You can make a digital twin of an airplane to make improvements in the airplane. You can do the same thing with cars, with buildings, a standard thing. Digital twins have been around for a long time. But can we make digital twins of people? So can you model health trajectories with digital twins? And why is this useful? So let's say a digital twin could be used to guide clinical decision making. So let's say I have a patient, and let's say I can make 3 copies of them in the computer. And I'm trying to decide what medication is best for this patient. Well, if it's my physician, and they said, well, I've got these 3 different drugs, I don't know what's best for you, they all have side effects. Why don't you try this one today, and next week come back, try the second one, and the next week come back. I would change my physician, right? Right? But what you can do in principle is you could give this drug to this digital twin and generate a trajectory. Just like you generate words in ChatGPT, if this model learns the patient, it can generate future trajectories in response to different queries. Right? So like ChatGPT, you have a query, it provides words. A query could be response to a particular drug and get a trajectory. And then I could find out in an objective way whether which drug is best. So the drug B here is the one that has no hospitalizations, and I can do this in an informed manner. You can do experiments on patients and derive at the optimal care in a personalized manner. Now there's a lot of suppositions here, right? So we have one way to do this is you could take the GPT model. So GPT stands for generative pre-trained transformer. And a transformer is a type of neural network that is performant with respect to this task in the language domain, right? It's pre-trained because you have a large corpus of data in which you've trained it, and it's generative. It generates words, generative. It's pre-trained on a large corpus of data, and it uses a type of neural network called a transformer model. So you could take each of the patients in some data set and just use a transformer model and train it. And you could do that. Now, this is challenging because patients are different. Here, so I've got like all of patients in this, but there are different subgroups. My patient profile is different from my wife's, is different from my kids', is different from my colleagues'. And sometimes these differences are easy to appreciate, and sometimes they're challenging to appreciate. But if you could throw all of this into the model and have it generate and learn a digital twin for each patient. But and using some large representative data set. But the data sets are heterogeneous, as I've already mentioned, and I've tried to depict here with different colors in ways that are very difficult to appreciate. And this can make the training task very challenging. ChatGPT scraped the web, billions and billions of examples of words, a large corpus of words, more so than there are people on the planet. There aren't enough patients around, enough people to be able to effectively train such a model. So one of the things that we are doing, but if you could identify important subgroups, then you could train separate models on these subgroups, these transformer models, and get specific generative models for each of these patients. So what we are currently working on is a method that will allow us to, from some patient cohort, to identify on the fly different subgroups and train these generative pre-trained transformers to get patient trajectories. This is a very active area. Many people are working on constructing digital twins for patients generally. Not a lot of success, I think, because of some of the issues I mentioned on the previous slide. And this is what we hope that this will accomplish. So our goal at the end of the day is my last 2 slides. We want to be able to use low-lying data. In this case, I've talked about the electrocardiogram. We would like to have this information be sent to your phone and then sent to the cloud where we can do processing to get lots of information, some of it obtained in the hospital, and also for generative twin modeling. And this information gets sent to the healthcare provider that can inform their decision making, but it can also go to the patient so they can get a better understanding of their own health. And it's a communication between the healthcare provider and the patient, I think, that will prolong health and lifespan. Okay, so I'm just going to show a picture of people in the group. This is an incomplete picture. This is an incomplete slide. This doesn't have all of the people who I've had the honor of working with and mentoring, but it is a good number of them, so apologies and funding and so forth. Okay, that's all. Thank you.
Thank you, Dr. Stultz. We have time for question and answer session. If you have a question, please raise your hand. We have people in the back who will take the mics to you. So we have a question right here.
Has this progressed far enough where the communication from your device, your leads here, Bluetooth to your phone, information goes to the doctor, it can come back to you. Are we far enough along where that information would come back to you and your phone would just go crazy saying you need to get to the hospital within the next hour or something like? If you're an hour and a half before you identify it, does the FDA allow that? Will we be able to do that right now, or is it going to take more clinical trials before we can do that?
So, I'll give you. So there's no technological impediment to having that happen. Even some of this processing can happen on the phone itself. So the algorithm that I just described here, Chase, we've actually implemented on the phone that we don't need to go to the cloud. So the processing can happen locally. There are issues, the Bluetooth connections and stuff. It drains the battery and so forth. But from a technological standpoint, that's not the impediment. The question for me is, should we be doing it right now? That's unclear to me. So we have one prospective trial that's relatively small. We have another trial undergoing now where we are enrolling patients that already have an implanted device. These patients have very bad heart failure that measures their pressures, and that device stays in their chest forever. Right? But the advantage of relying on those patients is that they have real-time estimates of what those pressures are, and then you can correlate them, so there isn't this hour gap between that and the device. So, but the first question I would say is that it's not ready for prime time yet because it requires more testing, and it wouldn't be ready for the FDA. Also, the discussion about machine learning and FDA approval is a tortuous and challenging one. This is being recorded, right? Yeah. Right. So because I think the FDA is still trying to sort out what ML means and how it should be used. There's a company that I advise that is undergoing this process, this very painful process now. So it's a long-winded way of saying right now, no, but I suspect in the next 5 or 10 years, yes. In the next 5 years, definitely. Sorry, please.
Thank you for your talk. I had a more technical question about
Sure.
the transfer learning part, from 12 leads down to 1 lead. And then I was thinking beyond that, if you went to, you have the current generation of monitor, you switch to the patients using an Apple Watch or a different, and can you talk a little bit about the losses that are incurred, the predictive loss, going from more information to less or different information?
Great question. So I will preface it by this, that the 12 leads in an electrocardiogram are not 12 independent pieces of information. In fact, some of the leads are linear combinations of the others. So if you went down to sort of the minimum amount, there's like it's maybe 8 leads or so that are independent of one another. And so we did a study where we did an ablation study, where we knocked out each of the leads to try to understand which lead was most important. And surprising to us, there was one lead that had the same performance as when you include all 12. So it was on that basis that we went to looking at a single lead, and it was lead 1, which is captured actually in the Apple Watch or in associated devices. Now, our first study, we did a patch monitor because that's not subject to noise. It sits on the chest. The watch can be noisy. And in fact, when Apple asks you to take a 12, you have to sit down, you have to be still, and you have to put your finger on the crown to get the 12 lead because of the noise issue. So the signal quality, I think, may deteriorate depending on how you acquire the signal. And a wrist-worn device is going to be more noisy than a chest-worn device. So those studies have not been done. The last piece of clarification, so when we go from a 12 lead to a 1 lead model, we do the stupid thing. We have the 1 lead, we replicate it 12 times, and we put it into the model and then fine tune it. Thank you for the question. Oh, yeah.
I have a question. I came in a little bit late, I apologize, and I don't know if it's being utilized in other areas of medicine. This is obviously cardiovascular, but has this been thought about, or are there applications being investigated right now for being utilized, like in pressure sensors for helmets? Like, I have teenage athletes, baseball, softball, football. Would you be able to train a neural network or something to where they take readings of pressures of hits or impact and be able to predict potential micro concussions and stuff like that? I know there's huge applications for professional athletes, but I'm thinking, in schools for high school athletes and stuff like that, or maybe even younger.
So that's a great question. I've got 2 young kids. I think my wife has forbidden my son from playing football. We'll see how that conversation progresses. The sentiment is well taken. There are a number of studies where using EEGs on the head and trying to correlate those with the concussive disorders, because one of the things you're concerned about is chronic traumatic encephalopathy, CTE, which is very prominent in boxers and in some football players and so forth. And I think one of the impediments in that vein is the data sets that you need to be able to do it. So we had at our disposal several thousand patients who had paired ECG and pressure tracings. From the standpoint of deep learning, it's not a huge number, but it's something we could do something with. And then we had another data set of 7 million ECGs that we could use in for some pre-training tasks. So we had data that were dispositive there. But there's a lot of work in this space. So this is not the only area in which the questions are a little different because it's not really about pressures so far. It's about this, and then there was also scanning that can be done otherwise. But that work, as far as I understand, and it's outside of my area of expertise, is ongoing. But I am aware of some of those work.
I'll ask the question while others are raising their questions. So the problem you're solving here is, in a big picture, target recognition, right? So in other disciplines, they do target recognition. In particular, the principles that are being used is look at it using multiple sensors, look at it multiple times, and look at it from multiple perspectives and combine them all together. When you have degraded sensors, right, that's what you're doing here. So looking at it over time, that's looking at it multiple times. I'm wondering whether there is an effort of using other cheaper sensors, combining the information from others to have a better accuracy in diagnosing and detecting the disease problems, whether there's an effort in combining that with AI technologies.
No, I think that's a great question. And so scientifically, for me, the question was, how much information is contained in the electrocardiogram for this task? And so we began with using with the ECG. And not to be disingenuous, we had lots of ECG data available that we could leverage towards this. But you'd like to be able to use all of the data that are available. So there's data from your accelerometer, for example. And I think combining accelerometer data with ECG data, I think will be 2 very powerful modalities that will improve performance here. And we've just chosen to do this in a stepwise way. just so we can understand the value of each of the components. But we'd like to be able to use all of the data that are available and in some multimodal setting where each of these different types of data represent different modalities. And there are ways in which you can combine different modalities or representations of different modalities into a bigger predictive model.
So just a follow-up question on that is, for our engineers and computer scientists in the audience, whether there's a need of developing those devices and sensors that will help physicians to do better work in terms of recognizing that.
And just to illustrate that, so this quantum computers, it's I think they're the biggest maker of laptops on the planet, became very interested in this work and in designing sensors that were complementary to this. So this goes hand in hand, right? Because you have to be able to get the data, the signals have to be high fidelity, the signal to noise has to be high. So there are engineering constraints and engineering problems in order to get data that are useful. And they have been very gracious in sort of lending us device and working with us to see how their devices can be improved to get signals that can be used along these lines.
Thank you for your talk. I was wondering, are there specific types of patient groups that you seek for your clinical trials and studies right now? And what kind of data are you hoping to gather from them that can improve it and further along the AI?
No, good question. So we've been really concerned in the heart failure application, because that's where, again, the patient, the problem formulation is all driven by the initial question that's important. And knowing how difficult heart failure is to treat as an outpatient is what drove this. So the line of patients and the trials that we are conducting have all arisen from the initial question. And the initial question was in heart failure. So all of our trials that are undergoing now are enriched with patients with heart failure. Now, we can get into the details because there are different types of heart failure and so forth, but as a general rubric, that's what it's been.
Hi, from the earlier of your talk, you said usually you want to see how well a model's accuracy is reflected onto a patient. You have a separate model that is tested against. So when choosing that second model, would you typically want an algorithm that is similar to the original model with like a different threshold or like features, or will you want to run a completely different algorithm when testing that model?
Great question. And I glossed over that. So the key point is the training data. So if you have another model built from the same training data, is it good enough for that patient? So in practice, I don't think it matters really the type of model. It's the data in which the model are trained. What we did in this case is our model actually predicts not only this left atrial pressure, but other things. So it predicts 4 things because it was built with this in mind. One thing we're interested in, and the other parameters, you can calculate the same thing. So we only have to apply the model once because it's built in 2 models that are in one, if that makes sense.
So the data that you train the AI on are patient records and patient history.
Mm-hmm.
So how do you get around privacy concerns with that? Because the best data would be, I think, probably like DNA data, but there's lots of ethical considerations with that, right?
So it's a good question. So I think two things. So all of the data that we acquired are under been approved by the Institutional Review Board. So we had to write out plans for the trial, for the study. It had to go to Institutional Review Board. Because it's a retrospective study, that was easy to approve. We have to de-identify the data when we actually put it into our models and such. So the protocols that we have to follow. With respect to DNA, I'm going to push back a little bit. Actually, I'm going to push back a lot on whether DNA is dispositive for this task. As you know, the difference between you and me in DNA is quite small, right? It's important differences, but it's small differences. And whether there's enough information in and of itself from the DNA to that's for this task is not clear. Indeed, many instances of heart failure are what we do to ourselves, right? And not necessarily our genes. Now, you could argue the my genes make me want to eat McDonald's 3 times a day, or not exercise. And that's another discussion. But my point is, it's a lot about the environment that impacts heart failure. The diagnosis, the management, propensity to actually have episodes of heart failure that are not really direct. The DNA is a weak signal for this particular task. That's my premise.
Hello, thank you for
Hi.
your talk. My question is more opinion-based, but just knowing that technology is a little bit inaccessible to everybody, my question as a doctor to you is, how do you think that this type of technology is going to impact health disparities and people that are, health disparities?
No, that's a great question. I think what the technology is useless if it cannot be used in an equitable and ubiquitous fashion. So our whole premise here is that we want to be able to devise a technology that will be accessible in principle to all. Apple Watch is expensive, right? But there are other devices that can also obtain an electrocardiogram that are not quite as expensive, and as time goes on, these prices will drop. But I think there are other sort of these patch monitor device and such which are pretty cheap that we think we can get pretty cheaply. And moreover, I'd like to see this be paid by insurance, right? Now, insurance in the US is a dirty word, right? Because the way that insurance, and this can be recorded, because the way that insurance happens in this country is a crime. There are too many people here who do not have health care, who should have health care. And it is my view that health care is a right. So, so I am hopeful that we can incentivize people to actually, payers to be interested in making this part of routine care for patients with cardiovascular disease. Thank you.
So if it becomes ubiquitous, if everybody has an Apple Watch or something, and every time they're out of breath, they decide to check it, that data has to go somewhere. And I remember one of your slides, there was like 3 or 4 doctors standing in a circle, all trying to decide what to do. Mm-hmm. If there's millions and millions of these coming every hour, don't we get a bottleneck there?
No, I think that's a very, very good question. I think so. I have my own private patients that I see, and I carry a pager with me. And my patients, when something happens to them, they reach out to me and they expect me, as they should, to be able to get back to them. So I don't in an expeditious manner. So I think the data transfer has to be between the patient and their healthcare provider who has been entrusted with caring for their health. There has to be somebody where the buck stops, right? And that's the paradigm that we use today, right? I mean, you all have healthcare providers. We reach to them if there's an issue or not. I think the use case for the device is not everybody would have access to this. Because again, patients who, the 20-year-old basketball player should not have access to this. They should not be calling their physician if if this says that their pressures are high. The person with heart failure who has a long history of heart failure, multiple admissions, should not be wasting their time looking at their watch if they have symptoms. They should be on their way into the hospital. So my premise is that it's a narrow group of individuals in which that this is applicable for, and that it's best used, and so it has to be given and used under the guidance of a healthcare provider, as opposed to somebody picking it up off the street and using it.
So long term, do you see that 5, 10, 15 years down the road, the utilization of AI in these medical applications could open up a new area of support within the hospitals to help facilitate medical professionals, either the nurses, doctors, PAs, whomever it is, to help streamline the process right now, which could be quite onerous if you've ever sat in an ER room for 8
have.
or 18 hours
Yeah,
as a patient waiting. So,
Yeah.
so if this stream of data is coming in, do you foresee potentially hospitals or the healthcare industry having the opportunity to hire individuals that all they do is streamline data and make it packageable for the medical professional to distribute to the patient?
So I think it's a great question, and I think it really, a lot of these are economic considerations. I think there will be some people sitting down with calculators, doing the math, determining where the profit is, and how to organize a structure. So that's a challenging colloquy for me to have. My point of view is as a scientist and the physician who wants to do the best for their patient, and how it's implemented. And I hope at the end of however it is implemented, that these data remain and promote a discussion between the patient and the healthcare provider that's in their best interest. Please.
Hi, thanks for the information. I just have a quick question. So I noticed that since I just turned 22 recently, I wasn't able to do the ECG on my Apple Watch because Apple limits it to
Yeah.
only 22 and older. Are ECGs inconclusive on people that are young? Are you doing studies on children? Can you apply this to children that do face heart issues?
So I think this is a great question, right? It's about the accessibility of the signal that's used, and in what population. And because our questions always have begun with a particular problem. There's this problem in heart failure. How do we better the care of heart failure in those patients? And they've admittedly been influenced by my particular area of expertise, which is adult cardiovascular medicine. I think that there is a role for these sorts of methods in many other populations, but I think it really always has to be question directed. And then when it's question directed, then there are ways in which one can get the signal. You're right, the Apple Watch only allows you to do it because you have to enter certain information, ways around that. But they enter certain information, whether you have the AFib app, whether you have AFib or not, and your age and such. But these are all surmountable issues. My bigger point is that my answer is yes, and likely in many cases for many different populations, depending on the question in hand.
Thank you.
Sure.